Dr. Yasmin, you want to turn on your camera?
There's something wrong with the camera, so I'll just stick to this. Is that all right?
Oh, okay. No problem. All right. Good morning, everyone. Welcome to the Medico-Legal webinar. Thank you all for coming. Today we're going to talk about the clinical challenges during the COVID-19 crisis management strategies to prepare for the next wave. And for the moderator, we have Dr. Farique Rizal Hamid, Deputy Clinical Director of Hospital Sultanah Bahiyah. And then we have, for the speakers, Dr. Zainal Arifฟี่Omar, President of the Malaysian Public Health Physician Association, and Dr. Yasmin Gani, Infectious Disease Physician, Hospital Sungai, Buloh. Towards the end of the session, we will email you slides if the speakers or the moderator have any slides. Also, we will email you a e-cert and a feedback form. So I will leave it off to Dr. Farique.
Okay.
Continue, all right?
Yeah, sure. Okay, thank you, Carmila. Thank you very much. Welcome, everyone. Datuk Dr. Zainal Arifฟี่Omar. Yes, welcome on board. Datuk Dr. Zainal Arifฟี่Omar is our president of the Malaysia Public Health Medicine Specialist Association. Right, Datuk?
Yeah, betul.
Yes,
That's right.
okay, betul. And then Dr. Yasmin Mohamed Gani is our Infectious Disease Physician, Hospital Sungai, Buloh. Yeah, Dr. Yasmin?
Yes.
Yes, okay, great. Great for having our adorable and very thoughtful and challenging speakers too. And I'm Dr. Farique. I'm the moderator for today. I'm based in Alustar, Kedah. So Hospital Sultanah Bahiyah is in Kedah, is the hybrid hospital. Okay, before we're going to have a very interactive session, we go to all the speakers. I will have a brief and glimpse through of what clinical challenges they're going to have. I'm, as the Deputy Medical Director, we are more focused on administrative. We are the orchestra of whatever going to have a pre-planned in terms of to make it a reality. So for a clinician, the technicals, the challenges to make sure that preventive on Dr. Zainal in terms of make sure that the outbreak is cordoned and no spreading. And for a Dr. Yasmin as a curative physician is infectious to make sure that, everyone who got this COVID positive is cured and well, go back home. So I'll take off with the first slide. Okay, these are the areas of my hospital. Is that picture shows the hospital of Sultanah Bahiyah, and I'm sure there's a lot. Every state you're going to have a hybrid hospital and COVID hospital. And I'm sure Hospital Sungai Buloh is a COVID hospital in Selangor, with Dr. Yasmin is working. And administrative in terms of challenges. Okay. Now, as administrative in terms of principle of outbreak management, basically we portray in terms of strategic. You must analyze whatever data you're going to have, and the action has to be fast and precise. So what are the challenges is that basically what we're going to challenge in terms of good communication with the state. Okay, as administrative, you must have a very clear communication, excellent collaboration with the health, curative in hospitals and preventive and kesihatan awam. The good collaboration must be at par, including all other external government agencies that involve in disaster management of the state and national. So you're going to have basically these are the look of all the our old hospital building that we use specifically for COVID patients here. And these are the pictures, some of the pictures that in terms of administrative, it has to be a two concept. When the first concept is the managerial team, basically is all administrative, and basically our directors and all managers is all about fast decision making. It's 24 hours operational, solution based every issue. You must discuss issues with solution. These are the level that I think it has to be prepared, and daily brainstorming for every issue that come in, even small or big, and statistic interpretation center and proactive planning. Proactive planning is very well much so that the planning to break the chain of infection is still certain, and there is no more continuous chain of infection happens elsewhere after once you do your solution problem. And operational center, I mean, according to the hospital, emergency department, and also at the hospital itself, you're going to have 2 operational center, and it varies according to the hospital. Then, of course, you're going to have a psychology first aid team, that basically these people, this team going to make sure that our team is psychologically sound, and you know, stress management is at par, you know, fright management, frighting is at par, and OSHA team to make sure that our healthcare worker staff and frontliners will be very, you know, free from COVID. If they do have, then there is certain steps that we make sure that they are healthy and not need. So these are all the medical equipments that we need, long list of medical equipments, and again, clear communication, local plan, local or specific implementation guides for the hospital level, the state level, even, you know, we are doing very well at the national level. It's a bird's eye view and preparedness. You know, these are the pictures of hospital in Wuhan those days when they start building in. And a new normal, a new norm of living. And finally, hope the vaccine will be available in near future. I think, thank you. That's all for my slide presentation. You know, I will take off. I will pass on to Datuk Dr. Zainal, Arifฟี่, Omar. Datuk?
Yes,
You
Farique.
take off your part on the preventive part, and also how is the challenges at the preventive part. Can Datuk?
Okay, thank you, Dr. Farique, and very good morning to the participant and our fellow speakers. Yes, the topic today, the challenges for this COVID-19, as well as preparedness. Well, how prepare we to overcome any problem for the next futures. So before we go to this preparation or the challenges, we'd like to some sort of review our understanding on this COVID-19. So basically, COVID-19, the agent is coronavirus. Then the transmission, the main mode of transmission is droplet, and there's no treatment in terms of definite treatment, and there is no vaccine yet for prevention. So basically, we have to use whatever means we have. So in terms of patient or population affected by this COVID-19, there's a few group of them. First, about 80% of them, 80% of population who are affected by the vaccine, by the infection, asymptomatic, and they stay in the community. And maybe about 20% or more, they will suffer a serious problem or have a symptom, and most of them will go to hospital and they got treated, and about less than 1% will succumb to death. So this is the spectrum, the clinical spectrum of COVID-19. So for us in public health domain, so we have to tackle this group of people. I mean, people who are at risk, and also people who are got infected in the community, is about 80% of them. And then people who have symptoms and suffer from maybe mild to serious illness, and they are going to waiting for hospital, or called pre-hospital. And the third one, after they got treated in hospital, they're going to discharge. So this group of people in the community, before go to hospital and the post-discharge patient. So it has a lot of challenges for our people in the community, because once they got the infection, so there's a window period of 14 days, the incubation period from they got the infection, and then maybe they got symptom or not, and then later on they can transmit into the population, either through close contact or through public event or whatsoever. So the challenges is how we in the public health setting, first to identify this group of people who are at risk of getting the infection. Number two, who are at risk of spreading the infection. And third one is how to get these people to what we call in our management of COVID-19. These are principle of detect, treat, and isolate. So first we have to detect the patient, and then they got sent to facility for treatment, and then isolate people who are not going to the facilities or in the facilities from spreading the infection to others. So these are challenges because 80% or less than around 80% asymptomatic patient. So they will healthy, so they will walk around, they will do daily business either in the community or in the office or in their own house. So these are chances of what we call infection. So later on, when many people got infected, this will become what we call community infection. That means the infection is already in the community. You don't know. Maybe people around you, people in the market, people in the school. So there are some sort of people who are able, or they can spread the COVID-19 to you or to other people. So this is a very big challenge. This is what we already seen in this current situation in our country, Sabah condition right now, where there's a lot of cases, hundreds of cases pop up every day. And then we also now see the second group of people who got infected in Klang Valley, Selangor, Kuala Lumpur, wilayah Persekutuan. This is people who got infected from either non cases or from people who are asymptomatic or people who are already got the disease. So the challenges for us is number one, to detect through screening, and then later on to treat and then isolate them. So you can see that now big numbers in our country, either in Sabah, in Klang Valley, or in other states. So at the moment, we have to really depend on the team of health, public health professional or healthcare workers in the community. Either they are doctors, nurses, or other health workers, to go to do the contact tracings, and then to go to the locality to find people, as well as to monitor and enforce the regulation in quarantine regulation, or we call it movement control orders. So these are kind of tool that we have in public health setting. So you can see the huge challenges, and maybe later on after we can still continue our discussion after this. So Dr. Faris, I think I stop at this moment, and then we can continue later. Thank you.
Okay, thank you very much, Datuk. Okay, we're going to continue. Never mind, it's going to be very interactive afterwards. Then we move on to Dr. Yasmin Mohamed Gani, our ID physician of Hospital Sungai Buloh. Dr. Yasmin. Hello, Dr. Yasmin.
Yes.
Okay. I think you can just shoot off for your presentation and talk a glimpse of your part, Dr. Yasmin.
All right, just hold on a sec. Yeah, I'm just going to.
Okay, but so far the participants is about 30. Okay, welcome everyone. Welcome everyone. We're waiting for Dr. Yasmin to be ready. So just now we just finished our Dr. Zainal Arifฟี่Omar. Is a public health medical specialist. Datuk very, I think public health is play a major role, the ownership of this outbreak, you know, because 80% is asymptomatic, is there in the community. And Dr. Yasmin is very challenge proof in the hospital care for curative, and then to prevent that 20% of the infectious cases, which is really quite worrying. Okay, yeah. Okay.
Can you all see my slides?
I can see, Dr. Yasmin. Can.
Okay, great. So thank you very much for this opportunity of giving a little bit of insight. Sorry, I have many slides, but I will really try and run through them fast. My focus is mainly on some of the diagnostic problems or clinical or treatment problems that we may have, and a little bit about how the patients progress. Okay, so a little bit of short evolution of, sorry. Okay. Are the slides changing? In your slides changing, right? Okay, yes. Fine. So we first got to know about this in December, where it first started exploding in the Wuhan city of China. At that moment, it was actually called SARS-CoV-2 infection. And then subsequently, initially all the cases were linked to a seafood market, but subsequently we were quite sure that there was a lot of community spread that was happening. But in January, we started seeing cases outside of China thanks to global travel, and subsequently in the 20th January, a lot of cases were actually reported, and some mortality started coming up as well. 30th January, WHO declared it was a public health emergency of international concern, and it was renamed COVID-19 in February. And in March, the current declaration of pandemic status was announced by WHO. So if you see what happened in Malaysia, we started having the first case, which was imported from China. First few cases actually belonged to the first Chinese cohort and were diagnosed in Singapore. And then subsequently, we started getting some clusters from people who had a lot of epidemic, but majority of it was connected to China and travel abroad. And then subsequently, we started seeing huge clusters, the Uda Khazanah cluster, the public cluster, where we saw about 3,000 plus patients, healthcare worker clusters, about 600, 800 plus healthcare workers have been infected so far, a lot of local transmission cases, and local transmission cases, and of course, returning traveler. And now we are seeing a huge influx of foreign workers and PADI and party cohorts. So as of yesterday, we have achieved 5 figures, right? 22,225 COVID-19 cases, positive cases have been recorded in Malaysia. 64.6% of them recovered. The number are still in hospital care, and we saw a huge jump in the last 2 weeks. About 193 deaths have been recorded. Many among them are patients with comorbidities. So a little bit about how does it cause disease and complications. The virus majority of it attaches, the virus actually attaches to the ACE2 receptors in the body, all right? It uses its protein markers, and it attaches to the ACE2 receptors in the body. High amount of it is actually found in the lung, all right? But you have a few, you have some, but they are also scattered around the body, the heart, the ileum, the kidney, and the bladder. A lot, it's characterized mainly by hypoxemic respiratory failure. You have a form of DIC, which is marked by hypercoagulability. So there have been many articles that have been published so far, apart from just a hyperinflammatory drive or a cytokine-induced hyperstimulation or a storm reaction that mediates the lung injury. There's also a lot of microthrombi in the lung that leads to patients developing respiratory failures. And we also see quite a bit of complication of underlying comorbidities, especially in the elderly cohort, right? Now, a little bit about period of infectivity. I see a lot of people speculate, and a lot of studies have actually come out, that speculating what is the period of infectivity, all right? So this two paper aimed to answer these questions, and until now, I think it still stands still, so about 2,760 paired contacts, all right, close contacts, and the index cases were identified, all right? From there, about 22 secondary cases were identified. So basically what I mean is they identified some index cases, and then they did contact tracing and then identified 2,000 plus close contacts, right? Of the 2,000 plus close contacts, 22 second generation cases were identified. And then what they did was they divided the secondary contacts, positive contacts, into two exposures. One who had exposure to the index case less than 5 days of illness, another one who had exposure beyond 5 days of illness, right? So if you actually see, you actually divide it like that, those who actually got the disease from the index case, their exposure to them was actually less than 5 days of illness, all right? And about 2 of them were actually during a pre-symptomatic period. Those who actually had contacts with these patients beyond 6 days of illness, no one actually contracted the disease, all right? Then again, we started speculating, okay, so that means the period of infectivity is variably early on in the contact of the disease, right? So this one, another paper that actually came out that talked about period of infectivity. So they looked at 77 pairs of infector and infectee, right? So infectious period estimation was about 2 days prior to symptom onset and about 1 to 2 days after the symptom onset, right? So 2 days prior to the index developing symptoms, which is the pre-symptomatic period, and early days of the symptomatic period, all right? And right, subsequently, of course, we also want to see what's the spectrum of clinical presentation and how do we recognize these patients. This is the IDSA guidelines, and WHO has a similar table, right? It talks about typical symptoms of COVID-19, all right? Symptoms may appear about 2 to 14 days after exposure. A median day of exposure from exposure to developing symptoms is about 4 to 5 days, all right? So within 4 to 5 days, second generation contact can actually develop symptoms, all right? And what are the symptoms? It's not just respiratory, all right? It's not just cough, shortness of breath, fever, but you will also have other symptoms like muscle pain, headache, sore throat, and very distinct symptoms like new loss of taste or smell. Classically, patients will say, yeah, I don't have a blocked nose, but I can't taste or I can't smell. That's very distinct symptoms which are compatible with COVID-19, all right? And earlier on in the illness, when the whole thing started, we were thinking about ways of how to stage the patients, right? So we thought it will be good to come up with a staging criteria. Many of this is also supported by the international documents like WHO and CDC papers as well. So we divide the stages into 5. Clinical stage 1, asymptomatic, 2, symptomatic, but they have no evidence of pneumonia. So mostly upper respiratory tract symptoms, you know. And category 3 patients are patients who have pneumonia. And category 4 patients are patients who have pneumonia, but they require oxygen. And category 5 are those who need ICU care. Another way of looking at this is actually categorizing patients into mild and severe disease, right? Mild disease are basically those from clinical stage 1 to 3, and severe disease are basically those from clinical stage 4 and 5, all right? And as you can see, this is a snapshot of Hospital Sungai Buloh taken quite some time ago. It looks very different now, but majority of the patients who were admitted basically were in the mild category, all right, rather than being more severe category. All right, and this is the natural progression of the disease. A lot has been said and published about the natural progression of the disease, but basically it goes into stage 1, stage 2, and stage 3. So stage 1 is the early infection, all right? A lot of patients just stay in stage 1 and they don't progress on to stage 2 and stage 3, and they have spontaneous resolution of their symptoms, all right? This is when you can actually detect the patient's high by RT-PCR or the current available antigen tests, yeah, very earlier on in the infection, right? Subsequently, a fair majority of patients go on to develop stage 2. Even in stage 2, you can see many clinical criteria of the patient, okay? They may be an asymptomatic stage 2 where the symptoms are completely resolved and patients they may show signs of pneumonia, but they are very well, all right? They don't develop, they may have very minimal cough and then they get better, or they may have very minimal X-ray changes, but they have no symptoms, or the symptoms have completely resolved. These patients generally fit a more younger cohort, or you know, those with no comorbidities, but there are exceptions to every presentation as well, all right? And in stage 2 as well, some go on to develop a more severe pneumonia, right? Which is associated with probably some degree of viral replication. It starts evolving the basal pneumonia and then spreads to the periphery, and in severe cases then involves this entire lung with an ARDS picture. Patient starts getting shortness of breath or dyspnea. All right, the initial, so early way of detecting this is actually to ask patients for exertional dyspnea test, which is sometimes we started saying, even when people were actually performing their religious prayers in the hospital, a lot of patients, especially in public group, they couldn't even finish their prayers. So that was one of their early signs, right? Or even a walk to the toilet and come back makes them breathe a little bit more heavier, all right? Or we have some bedside exertional dyspnea test that we can actually do in order to detect these patients who are giving us warning. They may progress to a more severe stage. And of course, chest X-ray opacities and CT showing some ground glass. Now, how much of this is due to the viral response and how much of this is due to the host inflammatory response that leads to a hyperinflammation syndrome or a cytokine release syndrome is still not so very clear. There may be a clear overlap, but a good way of thinking is to look at the day of illness, right? So if the more earlier it is in the day of illness and with inflammatory markers are high and the inflammatory markers are not high, it is not wrong to think that there may be a considerable viral response or replication leading to this. Or if you're looking at somebody deteriorating beyond day 10 of illness in some laboratory markers, which I will discuss later, that points towards an increase or a hyperstimulation of the host inflammatory response that leads to a severe respiratory failure. So this is what I talked about before, right? So sometimes the viremia and the inflammatory response may actually overlap, right? And most of our treatment now, we understand it has to be a timely response, all right? So that's why we are quoting this Benjamin Rush thing. Skill in medicine consists of an eminent degree in timing of remedies, all right? When we catch them either at a viral response phase, but they are just mildly symptomatic, early pulmonary phase and late pulmonary phase, the treatment that we give may actually determine the success that we get in trying to cure them of their response, right? And who are the ones who tend to develop severe illness? So age more than 65, pre-existing pulmonary disease, chronic kidney patients, patients with uncontrolled diabetes, patients with hypertension, cardiovascular disease, patients with obesity, all right? And of course, those with severe immunosuppression. And when they tend to develop this, like I said in my previous graphs, about day 5 to day 10 of illness, all right? And how do we pick them up? So this is the warning sign that I was talking about. So a clinical warning sign or SOB on exertion, dropping saturation, persistent or new onset of fever, increasing C-reactive protein or a raised C-reactive protein, or some may have very high ferritin levels, persistent low or dropping absolute lymphocyte count, and of course, a worsening of the chest X-ray. One of the symptoms or a combination of the symptoms tells us that this patient is actually going to develop severe respiratory illness. All right, so the typical chest X-ray findings I was telling you about. So basically starts off more in the lower lobe, predominantly peripheral opacity, maybe single or multiple. Usually it's bilateral finding, all right, more than unilateral. But of course, you know, it doesn't necessarily have to be symmetrical, you know. But non-typical of COVID changes are pneumonia, lobar pneumonia, pleural effusion, pulmonary edema, and a combination of symptoms. So I'm just giving you a little bit of an X-ray. So this is a patient presented to us day 18 of illness. As you can see, a fairly sparing of the hilar region, isn't it? But you start seeing quite typical shadowing and infiltrates in the periphery, and it's much more clearer when they are deteriorating. You actually see a very typical X-ray change like this, right? Who are more likely to basically die from COVID, all right? So this was done in the initial phase of the disease, and it still stands whole right now. So a lot of patients, they tend to, patients when their age increases, so when you beyond 50 years old, you can see there's a stark increase on patients who develop severe illness. And of course, and after 60 years old, you know, there is a specific age-related mortality was also seen. Mortality rate sort of increases as the age also increases, right? And patients with comorbidities, you know, they have a more likelihood of succumbing to the disease, right? And how do you diagnose? This is another thing, all right? Basically, it's important to know who should we actually screen, all right? We should actually screen all patients with PYs, all right? PYs are basically those who have those who have history of travel and those who have contact with confirmed or suspected cases, you know? Or they're part, or they're coming from a known cluster or a DEMCO area or whatever. Looking, this was also supported by a recent one that came out. So residents, workers, detainees living in a confined living space, you know, institution, dorms, hostels, nursing home, prisons, depot, correctional facilities, old folks home, and of course, patients from known cluster, frequent healthcare contacts like those on hemodialysis, nursing home, daycare, frontliners in COVID-19 management, and of course, patients with SARI, that fit like a viral-like presentation. And patients who are unable to provide a history, you know, suddenly after motor vehicle accident or patient with learning disability who comes in, you know, suddenly out of the blue, you can't get a good history. And of course, an X-ray showing the pneumonia can also be a decision to actually screen somebody, right? This is just a general rule, but of course, this will be a good point to start to decide who to actually screen these patients so that we can isolate them faster, all right? And some of the available screening tests that we have are the RT-PCR, serological test, and the viral culture, all right? And if you look at this, what sample to collect, okay? So nasopharyngeal, mid-turbinate or nasal swab rather than oropharyngeal swab or saliva alone for SARS-CoV testing in symptomatic individuals, all right? If the upper respiratory tract sampling is actually negative, all right, it suggests a more lower respiratory sample if the patient is highly suspicious of COVID-19. All right, so a mid-turbinate swab is basically up here. So each depends on where you actually the swab. Mid-turbinate swabs, so apparently more painful compared to mid-turbinate swabs are much more painful compared to nasopharyngeal swabs. Whoever had a swab will probably know the pain. And the PCR is basically considered gold standard, highly sensitive, all right? And detects 2 or more proteins, at least 2 or more proteins. E protein is not very specific for SARS-CoV-2. It's basically it basically tells you have a coronavirus infection. That's about it. But you may, but a lot of the tests out there detects 2 or more proteins. Some detects up to 4 in certain private labs also. So M protein, generally the ones that everybody talks about is the RDRP gene. This is the one that is used to attach to the ACE inhibitor, you know, and then N protein. Then of course you've got the S protein as well. And the RT-PCR implications for practice. So the positive, like I said, it's very highly sensitive, right? But it may be specific. It's got a moderate specificity because the way you take the swab is also important. You know, the route of which you take the swab is also important. If the patient doesn't go enough, or if the patient just had nasal swab every day, you know, you might actually have you might remove all the epithelial layers and it may give you a negative swab line. You know, that's all the possibility. And of course, the cons to it is it does not distinguish between stages of disease and infectivity, all right? So we were using this last time where everyone was only discharged after 2 swabs were negative. I ended up, as you can see from this particular graph that I said, that I've put here, this is depicting a patient who was admitted and they showed prolonged viral shedding, even after seroconversion of the illness, all right? They used many areas, they used throat swabs, sputum, throat wash by gargling. I suppose they started doing this because it's very, it could be damaging to the mucosa. You see people start bleeding. I've even seen epistaxis from it all right? So and they can actually see no matter what method that you use, you seem to get a positive swab even 63 days, you know, it's about 2 months plus after first detecting the disease, all right? And of course, it depends on, we talked about this, depends on site and quality of sampling. Okay, the other one that's being used quite right now that causes controversies, or it can be extremely helpful, especially in areas like Sabah or in a cohort where you actually have a huge outbreak that is happening, all right? It's got a very high sensitivity. IMR approved it at about 84%. The advantage is a rapid turnover in testing in large quantities, right? And limit of detection is basically CT value of 30, all right? We'll talk about what CT value is, and the guideline has also been given on who we can actually use this, you know, in the population of patients that may use this from. Okay, and the cross reaction of influenza adenovirus was also not observed. All right. Now, however, all right, there have been quite a few false positives. The reason why there have been quite a few false positives is because if you use it in a population where you don't have a huge outbreak that's having, so a random person, right, who has no epidemic whatsoever, is not part of a cohort, and you do it as part of, say, some screening test, like a pre-op assessment or whatever, right? So, and let's say you have this scenario, RTK positive or the PCR is negative, the possibilities are many. You either have a very poor sampling technique, so no need to repeat, right? You actually have a possible intermittent shedding, or it could be false positives, all right? So there has been a lot of guidelines on how we manage patients, you know, who come in with an RTK and RTK antigen, which is positive, all right? So if the patient does not have any EPID link, you know, contact tracing is negative, we consider it false positive if 2 PCR taken 24 to 48 apart is actually negative, and the patient has no plus patients asymptomatic with no EPID link plus a negative contact tracing. So we have a lot of filters, also our safety net that we have to apply before we actually say an RTK antigen is actually false positive, right? A negative RTK test, on the other aspect, also shares that doesn't mean that the patient doesn't have COVID-19. He may be just incubating the illness. So this is how an RTK antigen test is actually done. It's basically an esopharyngeal test where the buffer, and then it has to be done in a lab setting where they would use the buffer and find out whether the test is positive or not. So if you actually have a test which is 2 lines like this, okay, may actually indicate both bands appeared. So one may be not very clear band, or this could be a very clear band. So if something like this is considered positive. So if you have no line at the T line, then it's probably considered negative. But if you have no control lines at all, then this is an invalid test, right? And of course, the other things that we have is the interim guidelines for antibody testing. It supports the clinical assessment, right? If testing after 9 to 14 days in addition to a PCR test. So this is what CDC was talking about. So in a setting where a lot of people are going to be doing antigen tests, PCR test and antibody test, and orthogonal testing regimes, that means testing approach, which means you use many different types of tests in order to identify whether a patient is positive or not. You may not get a real-time diagnosis saying, oh, in one day, in a few hours, you can say, oh, okay, this guy is positive, but you may need to apply orthogonal testing regime onto some people who come from gray areas to decide whether it's this patient is infected with SARS-CoV-2 or not, all right? Can be used to diagnose infection when patients present with late complications, yeah, such as pulmonary fibrosis, all right? That's another thing. Here, your PCR might not be positive, your antigen test might not be positive, but sometimes your antibody testing may be positive. And again, it also depends on the local prevalence of the disease. I have another slide talking about this, all right? So COVID-19 antibody testing relies on targeted antibodies, yeah, targeted antibodies. Sorry, hold on a second. All right. Targeted antibodies binding to the antigens, all right? Cross-reactivity, the other coronavirus is actually quite rare, but some cases have been reported and could happen, right? A positive test indicates COVID-19, but there is no data on neutralizing antibodies. That means if somebody has an antibody test which is positive, that does not necessarily mean they have neutralizing antibodies. What is neutralizing antibodies? Neutralizing antibodies is the most important thing to say whether you are immune to the virus or not. Okay, many of the viral infections, you don't get infected with SARS-CoV-2 again. You don't get infected with the same viral infection again because you produce neutralizing antibodies. But in SARS-CoV-2, data on neutralizing antibodies are very scarce, right? And antibody testing should not be used to determine immune status. So in a ward, when somebody is actually nicely discharged, you know, they have their stay in the ward, they're symptomatic or asymptomatic, and then they get an antibody test which is positive upon discharge, they cannot assume that they're completely free and they're not going to be infected with SARS-CoV-2 again. We can't give them that assurance, although reinfection has not really been consistently reported or significantly reported in all the other literature, all right? But so that's why we tell them there's no substitute for protective practices like masking and hand hygiene and staying away from crowds, right? Of course, there's also very poor data on herd immunity, right? Herd immunity is under the concept that if enough people get infected, then they won't be able to pass the infection to other people, all right, or unable to transmit it to other people. So herd immunity in worldwide studies has actually been very low, most less than 1 to 10%, all right? Even in Wuhan also, it wasn't really shown, all right? And a negative test basically could mean they have COVID-19 infection, or they could still have the virus, maybe due to timing. Maybe you're taking it too early, maybe you're doing it, maybe you're doing it too early now, or some people have such mild illness that they never mount a response. All right, so this is what I meant was it actually a sensitivity and a specificity of the test. A sensitivity of the test basically means how many people actually truly have the disease, and conversely, specificity means how many people actually do not have the disease, right? So the sensitivity and the specificity of the test depends on where are you doing the test. So if you do an RTK antigen or an RTK antibody in, say, currently in a prison in Lahadatu, a positive test means you're positive. A negative test means you're definitely negative, all right? As opposed to somebody randomly coming for a pre-op assessment, a positive or a negative test does not really mean anything. So that's why PCR test is probably better in those cohorts, but they also come. So again, we did a observation, and we didn't publish anything like this. It's basically for us to know and understand the RTK antibody. So we tested a number of people, all right? Some of them in the first week of illness, some of them in the second week of illness, some of them in the third week of illness, all right? And we actually see that the positivity, overall positivity percentage, right, that was positive, increases after the second week of illness to third week. It's much higher, all right? But if you do it too early, you will actually see, you might not see many that are positive. Of course, we had very little people that we tested in the first week of illness. Now, this is what a lot of people ask, treatment approaches, when to treat antivirals that are promising and antivirals considered miracle drugs, and antivirals that basically treatment that actually put out fires, all right? Now, when they treat, there has been a study, all right, that says that if you treat early, you're more likely to achieve success rather than if you start the treatment late. This, we don't use lopinavir anymore. This is Calitra, okay, once known to be a miracle, still known to be a miracle drug for HIV, but once when it first started, because of the mechanism of action, they thought it would be very beneficial for patients in COVID-19 as well, all right? So, so here they basically looked at patients who received within 10 days of symptom onset, as well as patients who received within after 10 days of symptom onset, all right? So if you treat earlier, it's probably better, and you actually get faster resolution of viral shedding now, and stop shedding faster compared to those who started the treatment later, all right? So on the basis of this, I actually want to go into some studies that actually have been, some study reviews. I promise to make it very fast. Antivirals that are promising. So if you look at remdesivir, has been touted as the miracle drug before, stops the drug from replicating by inserting itself into the viral gene, which increases mortality, odds ratio, and absolute effectiveness, 8.5% reduction, reduces time to clinical improvement. However, remdesivir, this was the famous paper that was actually revealed in NEJM, right? And remdesivir may have little to no effect on risk of mechanical ventilation, all right? So if you actually start it early, all right, it might have a good effect of reducing mortality as well as reducing time to clinical improvement. However, if you started late, right, as people who are already ventilated, might not have a difference, all right? So Wang et al. Also reported that those who actually received within 10 days of symptom onset may have benefited the most, all right? So there was a rapid recommendation. So remdesivir for severe COVID-19, we suggest remdesivir rather than no remdesivir for the treatment of patients with severe COVID-19, and their adverse effects were very minimal. But however, now we know we started early year definitely has a better option than starting it late. All right. So this is another drug that we are currently looking at, which is antivirals that are promising, which is favipiravir. All right. Originally, it was approved for influenza, as a salvage therapy for influenza in China and Japan. This is in they approved it even in 2014. All right, and they use it for influenza that has resistance towards or failed towards oseltamivir, right? So it was approved for influenza, and then subsequently it became approved for SARS-CoV-2 infection as well, all right? And it currently remains the drug of choice. Guidelines such as China, Hong Kong, as well as India is also, India's FDA also approved it for use for SARS-CoV infection. But the evidence around it is actually not very promising, which we'll go through. So one of the first two papers that came out regarding favipiravir is this, where they compared favipiravir versus Kaletra, historical cohort that were given Kaletra in the first week of illness, all right? And they saw the benefit of, and both arms were actually given interferons, all right? They were done, Kaletra and interferon was a historical cohort, favipiravir interferon was something that they collected as they changed their guidelines onto Kaletra to favipiravir, right? So none of these studies were actually very well done, as we know, in SARS-CoV, because people had to churn out papers as fast enough, so we can't wait for randomized controlled trials. So favipiravir actually had significant shorter viral clearance time, needing about 4 days as compared to the Kaletra group of 11 days. And also CT scan improvement was seen better for the favipiravir group versus those on Kaletra, all right? And this finding, where the CT scan improvement was best in those who were treated earlier, less than 7 days, all right? And we know that because favipiravir blocks and replaces the viral replication as it integrates with the host DNA. So that's why early treatment is better than later treatment. In favipiravir versus Arvidol with 12 days, which is another salvage therapy for influenza. And they saw both arms also received multiple drugs, antivirals, steroids, immunomodulatory drugs, and these are all major flaws that were seen part of the trial, all right? And as you can see, there were no significant differences were actually seen, right? And these patients were treated on an average 11 days after they were diagnosed as positive, right? Quite late, all right? And the evidence summary of for this, it's actually not very statistically significant, but none of the studies are really statistically significant when it comes to the antivirals that have been published so far, right? So higher dose is tolerable. So initially we started off with a lower dose, but higher dose seems to be quite tolerable as well. In influenza, just like in influenza, it has a proven efficacy if it's actually given earlier. So you can definitely consider it as a part of a package of treatment for patients presenting very early, all right? In faster clinical recovery, not inferior in resolution of symptoms compared to standard of care by day 7. It also shows some fast clinical clearance by day 5 of illness. However, since many of the treatment actually started a bit late, probably due to local recruitment factors, and the progression, so failure of favipiravir was also seen up to 20 to 28%, which may actually be just the natural progression of the disease, which indicates favipiravir may not have such a major role in stopping progression to category 4 and 5. But tolerability profile is actually very good. Okay, even in end-stage renal failure, this drug actually has no indications for, this drug has no data on giving to patients with renal failures, right? But some papers have been published where it is given to patients with end-stage renal failure without any problems, right? Without any side effects, all right? And these were drugs that were once considered miracle cures, like hydroxychloroquine and stuff like that, but the guidelines have been, so the evidence on hydroxychloroquine has been very, very scarce. As you can see in Malaysia, this is our Malaysia cohort, We looked at hydroxychloroquine versus a historical treatment group versus a historical groups. Previously, when our first 1 or 2 cohort of patients were actually coming in, we were not starting them on any treatment until they actually required oxygenation, as were everybody else were practicing it similarly at that point. So we looked at those category of patients, whereas patients where we were starting much earlier, somewhere around mid-March or so, when we compared them, we saw that deterioration in stage 4 and stage 5 pre-HCQ group and HCQ group had no significance, right? And of course, a lot of poorly designed study shows no benefit therapy or mild possible benefits, all right? There's no change in the rate of nasal clearance, was not associated with statistical to progression of disease. There were negative factors where there was risk of prolonged QT when used alone or combination, and then came the recovery trial showed no difference in mortality and viral clearance, and then hydroxychloroquine was removed, all right? And then WHO announced press statement saying that hydroxychloroquine has no clinical benefit for patients with COVID-19 infections. And of course, Kaletra, as I said before, was used quite extensively earlier in category 4 patients, but randomized trials that was in NEGM showed no decrease in time to clinical improvement or mortality benefit, all right? Very small studies actually said that may actually have some clinical benefit in certain combination, but at the moment, Kaletra is not considered due to also it has a very, very pronounced side effect profile. A lot of patients tolerate it very, very poorly, all right? So because of that, Kaletra is also flagged down as a miracle cure for SARS-CoV-2. But then came out this trial, recovery trial, that showed steroids had a great effect on mortality, significant effect on mortality based on the recovery group. And just to say, recovery group is a trial, a large randomized controlled trial in the UK that has many arms, all right? And the only treatment so far that they have actually received recommendation and shown efficacy is steroids, all right? And steroids, not in all cases, steroids in patients requiring oxygen showed a lower effect of mortality in patients who require oxygen versus standard of care. So when do you give this? When do you give this? All right. So generally, in order to understand the pulmonary phase and the late pulmonary phase, all right, as we talked about earlier, the viremia phase and the inflammatory response may to some degree overlap during the early pulmonary phase, where the patient presents with what we call as a happy hypoxia or a silent hypoxia. This is very touted by histopathologists as the L phenotype, or the intensivists as the L phenotype, where the patients present with a dry kind of lung, where they might not really be that acute, but they may start showing some signs of hypoxia. Eventually, it's a continuum of the disease. Eventually, I suppose the inflammations just characterized by an ARDS kind of a picture, plus late stage pulmonary fibrosis in the late stage. So this kind of patients may actually benefit from an immunomodulator therapy, and what more, and the drug that has been touted the best so far is basically dexamethasone and prednisolone. However, steroids, this was by the recovery trial. So steroids are also being studied by another, probably a much bigger trial called the Solidarity Trial, which is by the WHO, where Malaysia is one of the recruiting sites. I think they're looking at 83 countries or something like that, you know, and covering a lot of hospitals where they look at a lot of these antivirals plus some of the immunomodulated drugs that are being given, all right? So in terms of, and timing, like I said, timing is everything when it comes to, so maybe around here, antivirals will play a good job, but around here and here, you may actually need to consider using steroids, all right? And even then, a one-dose approach is probably not enough. all right, you probably need to think about a more graded approaches may be necessary in certain cases. And ideally, all this should be done in a clinical trial setting. All right, repurposed antiviral drugs. So this is what I talked about, Solidarity trials. Sometime last week or early of this week, they released this press statement and a preprint that brought a huge impact to the clinician as well as the world, waiting in anticipation regarding all these drugs that we are actually using at the moment. So unfortunately, favipiravir was not included as one of the drugs here, right? So repurposed antiviral drugs for COVID-19 interim analysis by WHO trial, which is still ongoing. You know, they haven't said they're going to stop, but they're still ongoing, right? So remdesivir, and they released a statement saying remdesivir, hydroxychloroquine, lopinavir, interferon regime appeared to have little or no effect on hospitalized patients with COVID-19, as indicated by overall mortality, initiation of ventilation, and duration of hospital stay. So when this came out, there was even more talk about, oh my God, what do we use, you know? But still, the trial is just an interim analysis, and at the moment they are still recruiting arms for remdesivir, and they're also looking at tocilizumab and as well another touted miracle drug earlier, which is an IL-6 targeted inhibitor. It's a monoclonal that's actually used to stop IL-6, which was thought to be one of the drivers of the pulmonary phase. However, more and more evidence are being released saying actually IL-6 markers compared to other disease that cause a similar kind of ARDS are not very high, and the word cytokine storm may actually be overly used in these patients, and we are probably just looking at a viral application, a combination of symptoms that's leading to massive hypoxia rather than just one therapy that's leading to hypoxia. The other thing, there's another group that basically thinks tocilizumab is also a time-tested strategy, meaning the timing is very important. So if you give it very early, it might be good, but if you give it very late, it might not have any effect. Tocilizumab, there was another trial that was actually published that talked about tocilizumab having no effect or little mortality on patients who are already intubated. So this needs to be studied in even greater depths, yeah? And this is ongoing still in Solidarity trial. And convalescent plasma is another mode of therapy that has very little evidence, some promising, some not so promising, but our local experience in up north in Kedah has actually been quite good when CP or convalescent plasma, the whole benefit of CP, the whole concept of CP is basically you're taking antibodies from people who have recovered from the virus and you're giving it to very sick patients, right? So if we give CP to very sick patients and the hope is you actually have enough antibody, you're providing them with guns to stop the progression of the disease. And up north in Kedah, recently there has been quite successes in anecdotal cases of using CP and avoiding intubation or a faster clinical response from ventilation, right? So at the moment, in our guidelines, this is how it looks, all right? We don't, because I know I said we should treat early, but not every single patient requires treatment, all right? As I have shown a very early slide before that says that these treatments, there's a certain group of patients who tend to progress, all right? And maybe treatment initiated early in these certain group of patients would have some beneficial effect rather than starting it for patients, starting it for all patients, all right? So currently category 1 and category 2 and in some category 3s, right? In some category 3s, we do not start any antiviral treatment. However, if patients show any warning signs, as I presented in the earlier slide, or patients who are more than 50 years old with comorbids, patients with end-stage renal failure, and patients who present with warning signs, they are treated early as with favipiravir. And another thing about favipiravir is most beneficial if it's only given early. So if a patient presents much later, already requiring oxygen, it is most likely that favipiravir may not be of benefit, and we may consider experimental therapies or even steroids or even convalescent plasma, plus a local, very good monitoring and so on in these patients. Very good monitoring and a close observation of these patients, yeah. One of my last few slides, I think, addressing hypercoagulability. Like I said, there's a lot that has been talked about, the progression into a more severe disease. The progression of more severe disease is a multifactorial rather than just one factor which is driving the disease, yeah? So it could be microthrombitis, and a lot of postmortems have also shown that there are extensive microthrombitis in the lung, which actually may be one of the main or supporting pathophysiologies which drives the progression into extreme hypoxia, right? So we have also included hypocoagulability now guidelines, where all category 4 patients who are requiring supplemental oxygen start developing, are given an oxyperin, all right? And a lot of these patients have confirmed venous thromboembolism, or we are suspecting them, but we can't prove it now because the patient's too ill to get a CT scan or a CTPA done. So these patients are also given full dose anticoagulation, and some patients were even considering very high prophylactic dose of anticoagulation, right? In maybe those ICU patients, and also those who have very high D-dimers. All right, and other interventions we keep driving are basically coming up with monitoring guidelines, you know, even in low-risk centers, self-proning. So patients in category 4 are told to self-prone and tell them to completely rest in bed. And of course, looking at drug and drug interactions, and we start using more experimental drugs, more drugs are being used to treat SARS-CoV-2, all right? So this is generally our approach when it comes to patients who are admitted for more severe SARS-CoV-2, all right? And some of the challenges that we may face in the coming months could be a few. Of course, the search for the effective antiviral may just mean good timing, all right, rather than trying to find more new drugs. And of course, how will we? Many countries saw this, right? Many countries saw after the CMCO or the MCO order has been lifted. Many countries saw another spike, as we are seeing right now, managing hospital outbreaks, you know, driving the practice where you actually have to condition yourself to think every person that you are interacting with is actually infected. That will make you and keep you at your toes at all times and help you practice social distancing. And of course, management of non-COVID patients. A lot of our hospital is seeing a huge paradigm shift, isn't it? Especially these hybrid hospitals. Sometimes it's very difficult. You know, Sungai Buloh was a known center for ophthalmology, infectious disease, HIV care, neurosurgical, and suddenly over the few months, you know, we had to repurpose our existence in Sungai Buloh and effectively come up with management strategies to help other patients as well. It's not an easy, it's actually quite a daunting task, but it's something that we want to improve as we go along, as most likely will be in this situation for a long time. And I'm sure what I'm saying is also the same for many other hospitals, yeah? The sheer volume of patients, of the COVID-19 patients that we have is overwhelming. At the moment, we are quite comfortable with the placement that we have, but if the volume is going to explode even more than now, all right, with very minimal staff, and with Sabah needing a lot of help from us, from all of us across the country, and duly so, right? The placement of patients, we need to think about placing patients, stepping down care, self-assessment of patients, rather than one doctor seeing 110 patients, right? a self-assessment web-based, web-driven approach is probably great. So if there are any app developers out there, please come up with apps, that helps us in monitoring patients and self-assessment of their symptoms on a day-to-day basis. And of course, vaccine is still out there. We haven't seen any line in the tunnel yet. 2 trials have been postponed due to sun. So how vaccine is going to fit into the future is a question that has to be answered. And I'm sure there are probably many more questions out there that I haven't addressed that will come up in the near future. All right. So that's it from me. I hope that's okay.
Okay. Thank you, Lady Yasmin.
Yeah.
Thank you very much. It's a very fruitful talk. Okay. Well, I think I would we take off after this. I mean, any participants' question, I will open before, because there's a lot of Dr. Zainal and the talks and Dr. Yasmin. I think there's a lot of things that we might want to know more. So participants, I mean, about 33 of us, 33 of the participants. Any questions? Can they speak up, or they just chat? I don't see any chat coming in. No chatting. Okay, never mind. I can take off with the first question for Datuk. Dr. Zainal, we are talking about cluster. When you say it is a cluster, okay, then why there was a cluster? I mean, initial takeoff, there's not so many clusters, and now we're going to have many clusters. And how to break, to minimize the cluster that occurs in the community. But most important, what is cluster? Why cluster, and what is the strategy of having a cluster to cordon this outbreak? If you have any idea or anything that can share.
Yes, Dr. Farid, this what you call cluster is a very loose term. Previously it used cases, but as cases come in, so there's many cases, so we have to go to something, group them for easy intervention. So cluster mean there's one index case. Maybe one case who are infected, and then this patient transmitted the disease to other people. So it can, this is what we call, they can affect maybe 1, maybe 2, or maybe more. So at the moment, studies show that one patient can transmit or infect another 2 or 3 people. So when there is one index, and then a few cases coming from this index case, so we call it cluster. So at the moment, ministry have given a name, for example, cluster Kasturi or cluster Penjara. So this means that the index case was found in Penjara or in the apartment, and then few other cases result from this index. So in terms of intervention or managing, so what you call, say for example, there is a 10, maybe 100 people living in apartment Kasturi. So they call a cluster Kasturi, and the one in that case, and a few positive case. So the authority, I mean the government or the Ministry of Health, have to go to that cluster and do screening of all individuals in that cluster, and then find out either positive or negative. And in terms of intervention also, this cluster sometimes to control the cluster from giving more cluster or more cases, so we have to isolate the index and isolate the clusters. I mean, if the Kasturi apartment, you have to isolate. The problem is now, I think many people have said this, after the PRN Sabah, so a lot of index cases. Index cases come back from Sabah, they spread around the country. So this create a cluster. That's so, for example, now about 26 to 29 clusters in Klang Valley resulted from the index case from Sabah. So it's very simple explanation.
Thank you, Datuk. But basically, you know, the cluster is we want to identify the index cases and the spreading. And, you know, we have a strategic planning to condone the situation so that it does not getting worse. Okay, Datuk. So
yes.
I think there is a chat for Dr. Yasmin. Dr. Yasmin?
Yeah.
The question is, how do you decide which steroid to use for COVID patient? So I know that just now we're talking about metronidazole and you know, they got two types of steroids, right?
Dexamethasone.
Dexamethasone. So how you decide? I think Miss Mei Li Ling, Meng Li Li asked.
Yeah.
Okay.
So it depends on the clinical presentation. So if I think the clinical presentation is very severe, actually most of the cases we end up starting patients on dexamethasone. We're a bit, because these patients present to the ward and stuff like that, we tend to start patients on dexamethasone first. And but a certain and majority, I would say 70 to 80% or even more than that of patients actually respond to dexamethasone at a graded bolus. So the more severe we might give a much higher dose, like 6 milligram BD or something, you know, as compared to a daily dose. So someone needing nasal prong, not much infiltrates on the chest X-ray, so we look at certain things to decide if the inflammatory markers like ferritin and absolute lymphocyte count, and as well as the CRP is very highly elevated, like more than 50, you know, or more than 100 and stuff like that, we may want to use a much higher dose of dexamethasone as compared to a lower dose, right? So we tend to start with dexamethasone first, right? But the key to here is monitoring the patients very, very closely. So we monitor the patients in a high setting very, very closely. Either they will be in ICU or they will either be in a ward setting, but a HDW kind of a setting, isn't it? High dependency ward kind of setting. And we monitor them very closely for their response. Some patient may require a rescue methylpred at a much higher dose of 1 to 2 milligram per kg. All right. Now, we don't know if we just continue and watch these patients on dexamethasone, they will improve or not, but some tend to require much higher doses. In those patients, sometimes an upfront methylpred, like if they come in intubated, they come in intubated already, or they come in with a high flow mask and stuff like that. And after ruling out infection, after ruling out and stuff like that, infection or a PE or, you know, pulmonary embolism or something else that's contributing towards a very high ventilator setting or oxygen requirement, you need to make sure you figure that out first before you give a very high dose of methylpred, isn't it? But we are comfortable using dexamethasone as our first line, and because majority of the patients do.
Okay, Dr. Yasmin, and furthermore, okay, I remember the graph that you presented just now.
Yep.
You know, there is a cross stage 1, 2, and 3, the inflammatory, and also I think a virus reaction, the cross. Were there any rule for that stage 2?
That's what I said. So when you come at stage 2, if it's at a late stage 2, so
late stage, okay,
beyond the 7 to 10 days of illness, as opposed to an earlier stage 2, our approach might be different slightly. We may still be using steroids if we have significant inflammatory markers telling us that there is a hyperinflammatory syndrome, also drawing, you know, also pushing the patients into oxygen requirement. But if it's earlier, we may still add on antivirals. The antivirals might still have a benefit. And at the moment, the antivirals that we're using is actually favipiravir. At the moment, we're using that. So, and of course, there are a group of patients where they would still require oxygen, but you don't see any hyperinflammatory syndrome at all, right? And you never know, they may come late, they may come just before day 7, and these patients may also benefit of antivirals. And some of the experimental therapy that we're talking about, which is the convalescent plasma. So I think convalescent plasma use needs to be studied in a bit more deeper, as opposed to just a single center observation, and we probably need to identify more patients for this.
Okay. For Dr. Yasmin,
Yeah.
since we are talking about drugs treatment, I mean steroid, another drugs treatment you're talking about is remdesivir and hydroxychloroquine. Okay, basically there's a long list of drugs treatment. What is the, I mean, you just simplify things so that you know, since hydroxychloroquine by now, we no use anymore, I presume?
Yeah, hydroxychloroquine has lost its
No, lost already, right? So
glory.
these are the high-end drugs that you're going to take off, right?
Correct.
Oh, okay.
Hydroxychloroquine is normal. That's why I put there. It's lost its glory already.
Yeah. So then do you put together the steroids and together with these drugs or whatever chooses for the stage, or you can do it independently?
No, generally because steroids have been chosen. I'm not promoting steroid use for everybody.
Yes.
But what I'm saying is you need to look at the clinical. It's important to know steroid is not a drug of cure. All right? You can't use steroids just randomly, just like that. So a lot of thoughts and discussion goes on between the intensivists and ourselves, and even among the consultants, before deciding which are the group of patients that benefit from steroids. Earlier on, we were treating all patients with antivirals, but as a new disease and more evidence come out in the Solidarity trial result that has come out that shows that all these, in Solidarity trial is actually a very big trial and is the best randomized control trial that we have so far, right? And of course, we are eagerly awaiting all the recovery trial results as well regarding all these steroids and stuff like that, and regarding the antivirals that they are also studying, right? So these two studies are very big. And the interim analysis from all these two study drugs basically say that antivirals, if you want to start early, it may have some benefit. But if you're going to start later, it may not have much benefit, all right? So that's why it leads to our thinking and practice right now. So sometimes we may use them concurrently, sometimes we may use them just steroid alone or just antiviral alone. It really depends on how the patient presents, what kind of clinical factors are we looking at, what biochemical result in front of us, how much oxygen does he need. So it's a complex decision that we take on the ground to decide what kind of treatment to give. But at the moment, steroid is having its glory at the moment, right? Only time will tell whether, and don't forget, steroids also have some side effects, right? So we have to lay the benefit and the harmful effects of steroids before deciding who actually needs it, when do you actually give it, and who will just progress and get better without any treatment. So it's a complex decision that we make.
Yeah, I agree. Okay, at least that is a clear message that I think everyone should understand. Yeah. Talking about steroid, you have to clear, because anti-inflammatory, when talking about the graph related, then it has to be clear. Okay, now for Dr. Zainal, I think any other question from chatting, we can continue. We have another 10 minutes to go. Datuk, okay, 80% of the cases is very asymptomatic, Datuk. Okay, 80%. Okay, we are talking about challenges, and then just now your talks about, early on you're talking about is everywhere in the community, it's sporadic. When you have 80%, and then Dr. Yasmin is talking about, these are the criteria that when you get this COVID, this patient going to go into, later stage or, getting bad. So how are you going to balance in terms of preventive, okay, based on the knowledge that who are the people going to get bad, or who are the people going to be asymptomatic? So in terms of 80% or this 80%, so I'm worried because if 80% you don't really see through correctly and clear, so the outbreak of this virus, where are we going to come? Okay, Dato'? Are you clear
Yes,
now?
yes, Dr. Farid, these are the issue of the problem, or the big challenge for the COVID-19 outbreak control. For example, in Korea, in some Europe country and US or thing. So first, there's a large pool of infected people in the community. They are healthy, they are asymptomatic, and they are moving around. Say just for very cross estimate. For example, it's just 1% of Malaysian population, 30 million. So you can imagine how many in the community who got this infection, and they are now spreading around. And the other thing is our screening test. So when you screen a person, so the result may become as positive or may become as negative. We don't worry about the positive. They may be a portion of false positive. So sometimes they go to hospital and sometimes they stay at home, but they are controlled and got treated and isolated. The problem is negative test individual. So what are you going to do? Because there's a proportion, about 30% who are false negative. That means they have the infection, the virus, but they don't positive result. So this individual are a potential in terms of spreading. So that's very important in public health settings. Number one, whoever who got history of exposure, so you test and beside the result negative or positive, but you stay quarantined, either mandatory quarantine or self-quarantine, kendiri. So to isolate this from the community. Number two is whoever got the disease, so you send to facilities. We hope that we can stratify or profiling the patient who are mild and they can go to low risk treatment or managing centers, and who are severe or get complication, so they can go to a more hospital, I think, to be treated in hospital. Like Dr. Yasmin mentioned just now, who are the risk individual who are very risk to get severe and also to outcome is a death. So people are elderly, with chronic diseases, obesity, and don't forget about smoking. We have 50, nearly half of the country population, the male population are smokers. So these are people who are risk to have severe disease. So we should, I think, we now urge people who are good in AI, in IT, or to do a profiling of people who are from the community, so we can profile them as a low risk, middle risk, and high risk. So easy to control. But at the moment, we only hope that we rely on the test and we rely on the contact testing. Yes, Dr. Farid.
Okay. Thank you, Dr. Yasmin. I mean, is that Dr. Zainal.
Okay.
Whatever it takes, whatever you are at risk to get worse or better, you know, everybody have to practice the same way, 100%. Even you fall into that 80%, you still practice the same way as 100% group. I mean, yes. that is the message we want everyone to understand. And then Dr. Yasmin.
Yeah.
You know, I mean, I'm quite okay. Besides the test, RTK and PCR testing, very, very detailed. We've gone through. So in terms of your suggestion of the practice for hospital and screening, Dr. Yasmin? Yeah.
Still has the best.
Preventive and curative.
Okay. Curative, you don't need a test. I think the reasons because WHO has already told us, and it's even there in our discharge guidelines. You are not infective beyond, so you need to look at the infectivity period, right? So you're not infective more than 7 days of illness, right? The first few days of your day of illness is basically the time where you're most infective, is the time where you should be isolated, whether it's a low risk center, whether it's a hospital, whether it's an ICU setting, right? But beyond that, all right, beyond 7 to 10 days. So currently our discharge criteria is at day 10 of illness, and actually at day 11 you can go to work. All right. This is also practiced in many countries across the world, and this was even practiced by UK a long time before. All right, but of course they don't admit everybody. They do home isolation now. That's number one. The test of diagnosis, right? Entering into infection control, into the COVID care pathway. It depends on where you are. So many things. It depends on where you are. It depends on the turnover of tests, time to turnover of tests, and of course, the most sensitive test to diagnose whether you have the illness or not is a PCR test. Right? The antigen test that we use depends, number one, on timing. Also depends on the prevalence of the infection in that place. So if you currently do it somewhere in, I saw the graph of Selangor, which part is actually not really infected, and I think yesterday Sabak Bernam was still green, right? Sabak Bernam. So you go and do an RT antigen test there, it's going to have a huge impact. Even if it's positive, might well be false positive. If it's negative, might well be false negative. We can't use it. But if you take the same test and you do it in the Lahad Datuk prison or in Sabah right now, or in the middle of a Selangor outbreak right now, a positive test basically means you have the infection. Of course, you need to do a PCR test, but you can actually use that because the turnover of PCR tests in certain states is actually much slower, you know. So that's what I'm saying. So it depends on the prevalence of the population where you're applying the test. But if you're doing it for a surgical screening in a patient who is not exposed to anything, doesn't come, it's not a PY, patient doesn't have any epidlink, it doesn't come from Temco area, it's just a, you know, it's a preemptive screening lah, you know, then a positive RTK antigen test will actually slow down many of the treatment that the patients due to undergo. All right, so they will have to be admitted, treated as a possible case of COVID, and we need to do PCR testing for them. And some of these patients are waiting to undergo extremely complex procedures, right? So this is something that we should be wary before we actually do an RTK antigen test for them. But of course, in certain instances where the patient has to go for emergency surgery, right? RTK antigen test may actually be useful. So it really depends on the context of where you're using it now, because of the rapidity of the turnover.
Yeah, thank you, Dr. Yasmin. Is this just Dr. Yasmin? Do you, if you have any ideas in terms of this genotyping of this virus? I mean, the last questions I'm gonna ask.
I don't know anything.
I mean, do you have, you know, I mean, is it makes a difference in terms of management if you know about the types of this, you know, the genotype?
Even not really.
Yeah.
We don't know if the current super spreader COVID mutation is associated with more severe disease. I don't know.
Okay.
Clinical correlation like that has not been done, but I think but then epidemiologically it makes sense because it seems to spread quite fast.
Okay, we go back to Datuk. I mean, can you comment on that issue, Datuk Zainal? Zainal?
Yes, you know, you think thinking of this G164 D164 G of under the mutation. I know one thing in the principle of virus, the virus must survive, so they mutate in terms of time. So number two is majority of the current infection globally is caused by this D164G. So yeah, people say it's a super spreaders virus, so it can cause more infection very fast. So that's why I think because majority of the global infection is come from this mutation, so we have to like you said just now, practice the very strict for us to protect us and people around us to adhere to the strict SOP, you know, that simple wearing mask, washing your hand, and put as a physical distance. So don't worry about this one, but we have to.
Okay.
Maybe next few months they mutate another mutation. Yeah.
Correct. Okay. Thank you, Dr. Zainal and Dr. Yasmin.
Okay.
I think it's 12 o'clock.
Yeah.
Yes. Carmila. Yep. I think thank you very much for everyone. Any else Dr. Yasmin or Dr. Zainal wants to say?
No, I'm fine. Stay safe.
Yes.
Stay at home.
Stay at home and stay safe.
Yeah, okay. So all of us must stay safe and stay at home. I think it's going to be I hope it's a very fruitful session. And I pass back to Carmila. Yes, Carmila?
Any more questions from the audience?
No. Yes. No, I mean, based on chat, is no more questions. From me, yeah, I have lots of questions, but I think I stop until 12. Okay, I think that's it.
All right. Thank you, everyone, so much.
Okay, welcome.
Okay, thanks.
Bye.
Thank you.
Bye.
Bye.
Bye.